Hello students, my name is Ravi Chandra. I'm one of the course directors. I wanted to again welcome you to this virtual radiation medicine elective, which we're really excited to participate in with you. I also wanted to welcome you to this, the first in a series of mini lectures on core topics within radiation medicine. This first lecture will cover cancer staging principles as well as lung cancer. First, just a little bit about me. In addition to running this course, I also serve as a block director in HODI and wear some hats within both our residency curriculum and as the director of IPE within our department. Many of you may have been exposed to IPE within the undergraduate medical curriculum, and we're hoping to advance these sorts of principles and study them better, both in the clinical setting, but also in the graduate medical education setting. So we're excited both to pursue those initiatives, but most importantly to have you with us in this course. The first topic that I wanted to give you a bit of background on was, first of all, why we stage cancer and then how we do it. We're going to be experimenting with some new educational technology as we deliver this lecture, so we'll see how this goes. So the first question that we want to ask in staging cancer is the why. So, staging cancer is ultimately a record of the type of cancer that a patient had. So we may know that a patient has a breast cancer or a rectal cancer or a prostate cancer, and that says where the cancer originated, what organ it originated in. Of course, as you know by now, cancers of each organ are different. They're not all the same cancer. So it used to be thought way back when that all cancer was the same disease, and then we started to realize that no, not all cancer is the same disease. Cancers of the prostate are very different from cancers of the breast and from the rectum. And then, even within each organ, each cancer can be quite different. So for example, in the lung, as we'll talk about today, you could have cancers that are adenocarcinomas, more glandular type cancers. You can have squamous cell carcinomas, and you can have other types of cancers like small cell lung cancer. Lung cancer in particular has quite a variety of pathology. And then even within each type of cancer, so adenocarcinoma, for example, you can have cancers of different stages. So different amounts of cancer that really reflect the extent of disease. So the reason we stage cancer is in large part to be able to document in a concise manner the type of cancer and the extent of cancer that a patient has. These stages have some impact on a couple different fronts. One is it can help us think about clinical trials and treatment paradigms. So a stage 3 lung cancer might qualify for certain kinds of trials or treatment paradigms that a stage 1 cancer might not. 2, as patients proceed through cancer therapy, it's important for us to document how their cancer has progressed, because prognostically it gives us a lot of information as to how those patients are going to behave. So what you'll see in many cases, let's say for an adenocarcinoma, might be a designation that looks something like this. And we're going to talk about on this slide what these different terms mean. So the most important thing when we think about staging cancer actually is listed down here, and that is to stage it once. So what this means is when patients are first diagnosed with a particular cancer, they're staged after initial diagnostic tests are done, and they're not staged again. So if a patient has a right-sided stage 1 breast cancer, if she ultimately recurs from that stage 1 breast cancer, she will always be a stage 1 breast cancer. But we'll say it's stage 1, now recurrent. If she presented initially with metastatic disease, for example, then she would be a stage 4. One caveat to this is if she had a right-sided breast cancer and then had a second primary, either within that breast or on the contralateral breast, then she would be restaged for that new cancer. Each cancer gets its unique stage. So going back to the top here, so what do these TNM stages mean? Basically, the T stage has to do with the tumor. I hit something. Sorry. It has to do with the tumor. So this, and I'll show you an example of this on the next slide, but this is basically where we get some anatomic information regarding the extent of the tumor. Bigger tumors have a higher T stage, and every cancer has its own rubrics for how you define T, N, and M stage. In fact, it used to be that with the staging system, it was something that you could memorize, and for many exams, you were sort of expected to be able to know these things. But now the cancer staging systems have become so complicated. In fact, the book is probably as big as a dictionary now, that in many cases we use apps. For the cancers, of course, that you treat commonly, you'll know them by heart. N has to do with the nodes. So as you probably know, cancers typically originate in a tumor and oftentimes spread either through the blood or through the lymph nodes. And if a patient has lymph nodes, this is reflected in this N stage. So in the case of this example on the right, the tumor stage would be a T2. Don't worry about the C just yet. And the N stage would be an N1. M0 is whether or not the disease is metastatic. And typically M0 means non-metastatic. M1 means metastatic. Okay. These terms are amalgamated into what's called a stage group. Okay. And the stage group basically takes all the various combinations of T, N, and M and assigns it a stage. So this is the typical stage 1 through 4. Some types of cancer may have a stage 1A. In fact, even some cancers you hear about will have 1A1 and 1A2. But typically these will be stage 1, 2, 3, 4. Now, I am going to erase some of this stuff here, and I'm going to draw a little bit about when we think about stage 1, 2, 3, and 4. Typically, stage 4 is metastatic disease. Stage 1 tends to be early, called early disease. Stage 3 is typically locally advanced disease. And then stage 2 is sort of somewhere in between. It can sometimes be called early and sometimes be called sort of early advanced or potentially even locally advanced. You may see some terms like this. This is probably less important for your purposes now, but as you can imagine, some kinds of cancer are staged at the outset. So they're staged based on diagnostic imaging. So we take some scans and we look to see where things are. The problem is scans have a certain degree of sensitivity, meaning that there's only so small that you can see. And in some cases, doing surgery is more definitive for some parts of the body, and we can see, for example, exactly how much space a tumor takes up or exactly how many lymph nodes are involved. So it makes a difference whether that stage was assigned based on clinical information or pathologic information. Pathologic meaning once surgery has been done. So you see in my example up here that there's a C, which means a clinical stage. This means this would be a stage where a patient has been assigned typically based on diagnostic tests. So if the C designation means it's been purely clinical. P means pathologic. Now some cancers are staged pathologically, some are staged clinically. You don't have to worry for the purposes of this course as to which is which. Some may get both. So for example, you may see some tumors reported that it was a CT2N1, but a pathologic T3N2. It's the same cancer, but it just means that we got more information about it at the time of surgery. Sometimes we'll add a Y designation. This means after treatment. So for example, looking right here, let's say a patient had this particular tumor. that we gave some chemotherapy or some sort of therapy to up front, we will add a Y designation. You'll often see it after a P. So YP means that particular stage assignment was attached after surgery, but also after some treatment. And the reason for this is because we know that in the case of this example, there was some tumor burden at the outset, but we also changed it through the course of some treatment. So we need to be able to reflect that by saying we did something to it, even though we've also done surgery. U is a designation for an ultrasound type of imaging that's used in certain kinds of cancer. Again, don't worry too much about this, but just including this for your curiosity. Pretty much all sites of the body that we'll talk about, except for CNS, include a staging system. CNS also has its own staging system, but because the CNS doesn't have lymph nodes, and because cancers of the CNS typically don't go outside of the CNS, it's less useful to have the T, N, and M staging. Pediatrics, which we won't cover in this course, has a number of very strange is perhaps an overstatement, but very, very interesting and detailed staging systems that accomplish many of the same goals that I mentioned at the outset of this slide. But at the same time, they're really challenging, I think, to be able to remember and beyond the scope of this particular course. So, to give you an example, this is an example of the current staging system for lung cancer. One thing you'll note here is it's done by the AJCC, which is the American Joint Commission on Cancer. It's a cooperative group consortium of practitioners and folks who look at current data to see, well, how is it most useful to us from a cancer perspective to break apart different sorts of cancer? What sort of buckets do we need to put them into? Because ultimately, each of these buckets, which I'll describe to you in a second on this slide, they behave differently. And the reason why they each have different treatments is because we know that a stage 1 cancer is probably going to behave better than a stage 3 cancer. But do we know what makes the difference between a stage 1 cancer versus a T2B cancer or T2A or a stage 2A or 2B? Each of these cancers have different prognostics and potentially different treatments. I want to make a comment also before I go into this slide about the notion of T, N, and M and kind of where that comes from. I mentioned to you on the last slide that cancer has had an evolution in the thinking of both its personality and behavior and also the biology. One of the things that has been, I would say, a real change in our thinking of cancer over the past 5 or 10 years has been this notion that what we're seeing here on a staging system is really less about the extent of disease and more about the biology. So what I mean by this is, despite the fact that a patient has a higher end stage with more lymph nodes, the question is, are we seeing disease that's potentially more advanced, just meaning that it's been there for longer, or are we seeing disease that's more aggressive, meaning having more biological factors that predispose to nodal spread or metastatic disease? Undoubtedly, it's a combination of both, but I think what we're realizing more and more is some of these factors are more indicators of the biology that are driving the need for more aggressive treatments than they are all the same cancers on one continuum. Meaning that there are some cancers that may be, if you look at this lower right here, in one quadrant of this stage chart, that if given enough time may never ultimately go down to the worst corner of the stage chart. By contrast, and I'll erase this first, there may be cancers that originate down here or down here that have an easier time going over here, and these have more to do with the biology. So what is this chart, and what are we looking at here? Okay. So what are we looking at here? Ultimately, for this lung cancer example, on this left side, what we see are the T stages. So this gives you a flavor for how we break apart. In this case, much based on size, but it might have to do with where the tumor is located, invasion, or a combination of factors. And these can get very complicated. The end stage is listed here. And in this case, it's not just number of lymph nodes, it's which lymph nodes. And so we'll talk on the subsequent slides about nodal spread. And so certainly lymph nodes that are involved within the lung or the hilum are better than lymph nodes that are involved in the mediastinum, and then certainly better than lymph nodes in the supraclavicular region. So patients are assigned an end stage and a T stage, and then if they have metastatic disease, it might be metastatic disease meaning spread outside of the chest, but it also might be spread within the chest cavity. Each of these are put together and they're put into this table to figure out what stage they are. And you can see this gets pretty complicated pretty quickly. There are a couple different ways to become a stage 1A, but there are also several different ways to become a 3B and a 3C. It depends on, you could have potentially a high T stage, a high N stage, or a combination of both. So finding where a patient is on this table can sometimes be done by memory, because as you look at these, there's certain trends that you can see. So for example, if you have an N2 patient, he or she is going to automatically end up somewhere in the stage 3, whether it's 3A or 3B or potentially 4, right? And they're probably not going to be in this area. And so the same being true for N3 or higher T stage. So based on where they end up on this chart, we think about how they're going to be treated, and we use that to follow them through their course of treatment. So stage 3 lung cancer after treatment. Let's say this person had a stage 3 lung cancer, and she's a 42-year-old with stage 3 lung cancer who completed treatment, who now has no evidence of disease, or who now has recurrent disease within the chest, or now has recurrent distant disease. Okay, so with that in mind, let's talk a little bit about the lung and lung cancer. So lung anatomy is interesting, and in some ways it's complicated, in some ways it's simple, and perhaps that's the story of most of the cancers that we treat. The lung anatomy, as you know, is 2 lungs, and each lung is split into lobes. The right lung has 3 lobes. The left lobe has 2, plus the lingula, which is a smaller lobe that kind of is there to make room for the heart, which kind of tends to sit on the left side. Remember, we have the trachea that comes down. It splits into the right and left mediastinum bronchi, which then themselves split apart into the lobar bronchi, one for each lobe, and those split apart as well. The lung itself, of course, sits within the thoracic cavity with the heart in the center and some of the great vessels. We have some cross-sectional pictures, but ultimately, before we move on to that, what I want to talk a little bit about is how lung cancer spreads. So typically, lung cancers are cancers of the lung parenchyma, the meat of the lung. They tend not to be primary cancers of the lymph nodes, although those can sometimes happen. So what happens is these cancers tend to manifest in the periphery, and they tend to spread inward. So there are lymph nodes that you can find in the center of the lung. Those are pulmonary lymph nodes, or pulmonary parenchymal lymph nodes, and they come into the center of the chest through the hilum, which, as you recall, is that structure on both sides. It's kind of the way station for all the stuff going in and out of the lung. In the center of the chest is the mediastinum, and there are a bunch of lymph nodes in this area, and these are really important in lung cancer because these are the last stops between the center of the chest and the rest of the body. And so what happens, I'll change color here just for instructive purposes and also zoom in so you can see this a little better. What happens is lung cancer can spread through this up and out. So typically when we have N1 disease, there are nodes here. N2 disease is in this area. N3 disease is up here in the supraclav, and then metastatic disease is out. So this gives you a little bit of a flavor for why we have N1, N2, and N3 disease and what that corresponds to. The lung cross-sectional anatomy that you see here, we won't belabor for the purposes of this talk, but remember when you're looking at CT images, and you'll look at this a little bit more in the context of the radiology modules, remember that right is on this side, left is on this side of these images. Okay, and some of the resources on cross-sectional anatomy are helpful at being able to identify what some of the structures are. It's a worthwhile exercise to be able to do whether you're going to go into radiation or not. The lymph nodes in the center of the chest, just before we move on, and if we look down here, tend to fall within fat spaces. So you typically can't see lymph nodes if they're not involved by cancer. But if they are, they tend to get beefier. And so usually by practicing and seeing a lot of these images, you can tell very quickly what's normal and what isn't normal based on what is or isn't swollen. You can tell whether or not there's contrast. In this case, contrast has been used. Okay, and you can also identify different structures. So in your contouring exercise, you'll be able to contour things like the esophagus. You'll see the trachea here. You'll see the manubrium, the sternum up here. And you'll be able to identify the different vessels. So that'll be a fun and useful exercise for you. And so part of the contouring exercise is figuring out what the tumor is. And I think probably when I first started out, I wouldn't have been quite sure on this slide what the tumor actually is. And so looking at this tumor, or looking at this slide, I might have thought that this was. And maybe that's a reflection on me, and maybe you guys already knew which one the tumor was in this case, but this here is the left ventricle. And just to remember, and this is a PET scan actually, I should have mentioned that, where we look both at anatomic information but also functional information, meaning what is the metabolic activity of that. And of course, the left ventricle, as is the case with some other parts of the body, tends to have a fairly high basal metabolic rate, and that's why we can see the uptake of the FDG, the tracer right there. But in this case, what we're seeing is a small lung tumor over here. And because the rest of the lung doesn't tend to have a high metabolic rate, the ability to be able to use PET to identify lesions in the periphery is quite helpful. So one of the points I just wanted to make is that lung cancer, and some of these data are a little bit older, and some of the more contemporary data would sort of establish more optimism, but lung cancer tends to be a pretty challenging disease to treat. And I wanted to actually draw your attention to this. This actually was a study in California of patients who were not treated for lung cancer for a variety of reasons, and kind of what their survival was. There's certainly some challenges to studies like this because patients who aren't treated for cancer often are not medically fit to undergo cancer. So some of these data probably underestimate how long a really fit patient with stage 1 lung cancer would actually live. But the point is that patients with stage lung cancer still have a relatively challenging survival curve, even as compared with stage 4. Now, some of the advanced among you might say, well, this is probably the evidence that the staging system doesn't really seem to work because all the patients seem to look the same. And I think that's part of the criticism with a study like this. But the reason why I put this sort of study up is it's really the best and only data we have on what happens when you don't treat cancer. In many cases, when we have patients with cancer, they get treatment. And so knowing what would have happened had they not been treated is sometimes something that we don't have the best data on. And that can certainly impact our estimates of survival and other things. But what this slide, to me at least, motivates is that across the disease spectrum, whether it's stage 1 to stage 4, that some treatment is likely indicated. Because if not, we're dealing with a fairly challenging foe. You talked a little bit in the intro lectures about the concept of conventional radiation versus stereotactic body radiation therapy. And this is where we do effectively surgery with radiation without ever cutting on a patient. many of the data sets that we have would actually show a comparable rate of what we call local control, the idea that the tumor at that one site is controlled by the radiation, being fairly equivalent, if not exactly equivalent, or in some cases superior, because patients do better compared to surgery. The standard fields that are used in conventional radiation are much bigger, and the reason for that is twofold. One is older techniques, but also sometimes when we are treating a larger area, where we're treating lymph node areas, or we're using chemotherapy, or the tumors are very large, we have to treat a big area, and therefore patients are not candidates for stereotactic radiation, and instead candidates for conventional therapy. These sorts of therapies typically last several weeks. In the case of lung cancer, they usually are 30 to 33 treatments, so about 6 to 6.5 weeks, oftentimes with chemotherapy. Side effects are, as you know, dependent on the part of the body that's treated, the size, and so some of these treatments can be quite toxic on the acute perspective. Stereotactic treatment, by contrast, is a bit more user-friendly, but it treats a much smaller area. So really it's more treating specific tumors, and we can sometimes treat early-stage lung cancers or even low-volume metastatic disease to the chest. And these sorts of techniques tend to be pretty well tolerated, but this just gives you a flavor for what visually some of those differences look like. I talked a little bit about some of those lymph nodes, and you'll see some of those in cross-sectional anatomy. This is sort of a zoom-in picture of the mediastinum, and the lymph nodes that we talk about in the staging system are the N1, like we talked about, the N2 lymph nodes. These are all the N2 lymph nodes, and then N3 lymph nodes are higher up, which are the supraclav lymph nodes, which are not depicted on this picture. These different lymph node areas, or called lymph node stations, are located in different parts of the chest. So for example, level 7 is the subcarinal lymph nodes, located, as you might expect, under the carina. And there's specific anatomic boundaries for where we would see those, and which types of cancer are more likely to spread to level 7 versus, say, level 4. Some of these are subdivided into R and L for right and left, especially the ones that are running alongside the trachea higher up in the chest. There's some 5 and 6, for example, that are in relation to the aortic arch and the AP window. So ultimately, when you're staging one of these cancers, what you're doing is you're looking to see where these lymph nodes are that are either pathologically or clinically enlarged. And as we talked about, N2 really, as far as we're concerned, but prognostically, is perhaps the most significant in terms of what we call upstaging their disease. So what I want to do is talk with you just a little bit about treatment paradigms, and I have a slide here on the next slide that we'll fill out. But typically, big picture, when we talk about stage 1 tumors, it's really just a tumor alone. Typically no nodes, and typically small. And oftentimes for tumors like this, we can do surgery. Oftentimes it's a removal of a lobe, so potentially a lobectomy. There are other kinds of resections that you'll learn about in your surgery rotation. And one of the things that's important to keep in mind are surgical procedures that are oncologic versus non-oncologic. So there are surgical procedures that can be done to, say, remove a cancerous mole. But if you knew that that mole was melanoma, you would do the surgery differently. So, and potentially wider margins, potentially evaluation of lymph node beds, potentially different surgical approach. And the same thing is true in the lung as well. Stage 2, as we alluded to, are either bigger tumors or potentially certain nodes, but typically not nodes that are involved in the mediastinum. Stage 3 for us tends to be an area of active treatment. It's typically where we have N2 disease or big tumors. and then stage 4 is typically metastatic disease. And we'll also see those patients because we may be treating their metastatic disease in another body site. We may be treating palliatively to lesions that they have in the chest. So when we talk about locally advanced lung cancer, and this really is stage 3 for the most part, there's some different treatment paradigms for how we can approach this. So let's say, for example, let's start in the middle of the slide here. This is a patient who has a big tumor, and they're ultimately going to go to surgery. One approach is to give chemotherapy and radiation up front. We give it to a lower dose, and the chemotherapy is actually given with what's called sensitizing dose. Sorry, that's hard to read. Sensitizing dose. I'll erase that. Sensitizing dose is basically a lower dose of chemotherapy to help the radiation work better. And typically we give this first. And the idea is to try to shrink the tumor a little bit so that surgery can be performed. There's also some paradigms for the use of chemotherapy and radiation, either instead of this approach, or if surgery is not possible. If a tumor is too big, then the surgeon may feel that he or she just can't, no matter how well it shrinks, to be able to remove that much tissue. So in that case, we would give chemotherapy and radiation together, but to a higher dose, so we give more of it. The chemo would still be typically a sensitizing dose of chemotherapy, but it would be delivered with the intent to just give the chemotherapy and radiation alone for treatment. Oftentimes this will be followed afterwards by some more chemotherapy. And typically this is an effective regimen, although again, from the survival curves, this is a challenging circumstance. Typically, metastatic disease patients will get chemotherapy, and sometimes they'll get radiation if they have disease potentially that needs palliation. And as we'll talk about on the next slide, if potentially they need treatment for disease that is low volume spread, which we'll talk about. There are some circumstances where patients will get surgery up front. These are patients up here who are not initially thought to have disease that is stage 3 and who ultimately get surgery first. But when the surgeon investigates the mediastinum, he or she finds disease that has spread there that we could not actually discern on the CT scan. So some of these patients afterwards will get chemotherapy and radiation, sometimes together. This is, in this case, I'm going to put an S here for sequential, which means that they'll typically get the chemotherapy and then the radiation. So it'll be surgery, chemotherapy, radiation in the sequential format. And in this case, because these patients have either a positive margin or what we call extracapsular extension, which means the lymph nodes have so much disease that it's kind of leaked out, those patients will get surgery followed by chemotherapy and radiation together, typically to a higher dose. There's some other circumstances that we often see in radiation. One is we'll see a lot of patients for SBRT. These are patients who have small tumors in the lung that we'll treat with curative intent with SBRT. We see a lot of patients, particularly smokers, but other patients where we'll see this. One of the advantages of doing this, especially as compared with doing a surgery, which is possible, is especially in patients who are older or otherwise unfit for surgery or just don't want to do surgery, SBRT is a very reasonable option. As I mentioned to you, has a very similar control rate to surgery. So a very valid option and one that we see a lot. Small cell lung cancer is a different beast. And small cell lung cancer is staged a little differently, even though it does have a T and M staging. It actually is kind of broadly thought of as two buckets, what we call limited stage or small or extensive stage. Basically a little or a lot. The disease spreads rapidly. It does tend to be a disease of smokers, and typically it's managed primarily with chemotherapy, although in some limited stage disease we'll do a brief period of radiation in this case. Extensive stage patients will sometimes get radiation. This is a disease that has such a high propensity for spread to the brain that you'll often hear of the use of what's called PCI, or prophylactic cranial irradiation. It's actually, data exists that patients who get PCI, who have small cell lung cancer that's limited stage, actually live longer than those who don't. So we often will give radiation to the brain on a prophylactic sense for limited stage disease. Extensive stage patients we typically don't. Oligometastatic disease is a theme that you will hear about in a number of different contexts in the course if you haven't already. It's this idea that not all patients with metastatic disease behave the same. So what does this look like? When you go back to those stage charts, remember we had stage 1, we had stage 2, we had stage 3, we had stage 4. For stage 4, this was, as you recall, all metastatic patients. So not just patients who have 2 tumors, but it may be 2,000 tumors. It may be more than that. And it's not unsurprising, perhaps, that a patient with 2,000 tumors might behave differently than a patient with 2 tumors. The question is, could we potentially cure a patient with 2 tumors when we know we couldn't cure a patient with 2,000 tumors? A lot of skeptics and sort of the thinking in the field had been, oh, well, actually, no, we can't, because once the tumor's demonstrated its ability, its biology, to not only be capable of metastatic spread, but a desire to do so, that it's just a matter of time, that even if you treat 2 tumors, you'll see more pop up and you'll just be playing whack-a-mole, that these patients just need chemotherapy. This continues to be a valid argument. But what some folks have also noticed is that not every tumor in the body, once it spreads, behaves the same. So despite the fact that we have, for example, a lung adenocarcinoma, these tumors tend to have such great genetic diversity that when they spread, the metastatic sites may or may not have the same genetic makeup or capabilities that the primary tumor had, or even another metastatic site had. So when you give them chemotherapy, for example, not all the tumors respond the same way. So some folks have posited, well, maybe we need to treat some of these tumors differently from others, meaning that what if we gave chemotherapy and then gave some treatment to sites that didn't respond well? Or maybe if someone comes in with a small volume of tumors, we could treat all of them aggressively and hope for the best. And so there have been some trials in radiation, I would say over the last 5 years or so, and this really is an active area of research where folks are starting to think about pragmatic approaches to treating low-volume metastatic disease, what we call oligometastatic disease. Another term that you might hear is called oligoprogressive. And this is basically where you take the 2,000 patient, you give them some chemotherapy, and what happens then if they now have 2 tumors left over? And this happens. Could you consider treatment to just those 2 tumors to clean up what's left over? The answer is yes. So data are maturing in this way, and in many cases we'll use SBRT type technology to be able to treat oligometastatic disease. But this is a term that you'll be hearing more about. And in the lung, the reason why I bring this up is because the lung is a fairly common place where we can see oligometastatic disease, or patients who've had, say, stage 3 disease that now have a new, what we call a new MET in a new part of the body. And if it's a small volume disease, we certainly can consider giving them a second chance at cure. So that concludes the talk on lung cancer paradigms. Just to refresh your memory before we finish, we talked about cancer staging, and we talked about how cancers are typically staged once. They have a T, N, and M stage, which is amalgamated into a stage grouping that impacts prognosis and it impacts treatment. We talked about the difference between clinical and pathologic staging not being something you need to focus on, but that just to be aware that different cancers are staged based on clinical versus pathologic, sometimes both information. We talked about lung cancers, and we talked about how the spectrum of disease that we can see in radiation oncology spans stage 1 to 4. Many of our stage 4 patients tend to get palliative type treatments, and in some cases, definitive treatment, definitive meaning potentially curative treatment, as oligometastatic patients. Oftentimes, the stage 1 patients will get SBRT to specific lesions with curative intent, usually just to that lesion, in a very focused, small radiation treatment field. The stage 3 patients will typically get larger fields, often with chemotherapy, because they have disease that often has N2 lymph nodes, sometimes a really large tumor, which I'll depict as a big T. These patients will often get a combination of all three modalities of oncology: surgery, chemotherapy, and radiation, and the combinations of which are helpful at potentially either downstaging a tumor prior to surgery or being treatment alone. Incidentally, before I finish this lecture, the stage 3 example, it highlights a reason for the Y designation for cancer staging. So for example, a stage 3 patient who ultimately gets upfront chemoradiation going to surgery might start out with a clinical T3 N2, but at the time of surgery have a YP T3 N1 because they've had some chemotherapy and radiation before their surgery. This doesn't mean, because they ultimately came out with an N1 tumor, that the upfront chemotherapy and radiation was unnecessary. In fact, we could consider this potentially a response to treatment. By contrast, a stage 3 patient who gets chemoradiation alone would remain a CT3N2 throughout and would never have a YPT stage because they never had surgery. Anyway, so thanks for listening to this first lecture, and we'll talk to you later.